And I'd like to thank Dr. LeSar and the group for inviting me back to this meeting. You know, I was thinking about when I met Dr. LeSar in 2018, and I was invited to this meeting back in 2018, Tina. So it's really nice to come full circle. Thank you for the warm welcome. Oh, hey, Dr. LeSar. Excellent. Okay, so I'm going to talk about CLTI and some different approaches to ultrasound in these complex patients. I think we can all agree is these patients have diabetes, renal failure, they're really complex. And therefore, when you see a patient with a TMA and gangrene of their first toe, maybe our current non-invasive diagnostics tests may not help us to determine what the perfusion is like in the foot. And we have a plethora of non-invasive tests that we've had for decades, and they've served us well, I think, in the smoking population. And now that we see the increase of diabetes, we need a new way to evaluate foot perfusion. So I'm going to talk about a new test called pedal acceleration time, or PAT. And you can see highlighted in yellow here that this can be a valuable test. This is using standard ultrasound to actually scan the arteries in the foot. And this is very valuable when your patient looks like this and they have no toes, and we have to tell Dr. LeSar what is the blood flow like to the foot. So I actually developed this technique in 2017 by just scanning my own foot, and I realized how well we could see these vessels in the foot by using ultrasound. I worked with my vascular surgery colleagues for 2 years to really evaluate how we're going to quantify the perfusion, and we looked at ratios, flow volume, waveform analysis, and acceleration time really was the most sensitive and specific. So our criteria is published in the Annals of Vascular Surgery, and PAT is broken up into 4 classes. Class 1 being normal. This is consistent with no symptoms and reliable normal ABIs. So in this early criteria, we just put PAT up against the gold standard of non-invasive, which is ABIs. These were non-diabetic patients, so we felt ABIs to be reliable. And so when we go on to the classification, class 1 being normal, then we have class 2, which is more consistent with long-distance claudication, class 3, more consistent with short-distance claudication, and then class 4 is the worst, which is consistent with tissue loss and rest pain. So pedal acceleration time is just the measurement of time in milliseconds of how fast that waveform is rising. So it's a number in time, it's an objective number that we can then put to this criteria and say, you have mild ischemia. And why I love it is because I think we should change our approach to how we are approaching patients with CLTI, is starting at the wound bed first. And so you can see when I put the probe at the base of this wound bed, we see an abnormal acceleration time. This is class 4, and within 1 minute, you know what the perfusion is like in the foot. It's fast, it's objective data, and it is reliable if done appropriately. So we can use this criteria and apply it to any vessel below the level of the ankle, and ultrasound is so flexible that no matter where the wound is, we can put the probe proximal to the wound bed and understand what the perfusion is like to that wound. But technique is really important. We cannot have a small waveform. Just like Tish said, we have to stop, we have to optimize and make sure that we're measuring appropriately. That means lowering your baseline down, increasing your sweep speed to see about 4 cardiac cycles, and make your waveform really large. And if you need to, you can measure acceleration time in every single one of these waveforms. And you'll see here that the acceleration time is 64. That is normal at class 1. So let's fast forward to 2025, and I teach globally, and there has been so much incredible global collaboration that there's over 25 publications of pedal acceleration time. And we have other groups publishing the correlation of PAT to toe pressure, to TCPO2, and PAT is certainly predictive of wound healing and limb salvage. And Speaking of that, we now use it. I work with an interventional radiologist in our OBL. We use it as an endpoint on the table to determine when we've done enough revascularization and we can be done. Because these patients, have significant tibial disease, and sometimes we can't always open the inline vessel to the wound bed. We have to indirectly get blood flow there. And you can see my probe is just sitting at the wound bed while Dr. Constantino is just opening up vessels, and we're using that number to say we're done. This is a recent paper that came out of New Zealand, looking at using PAT as a surrogate in forefoot amputation. And then just in 2025, there's all of these papers that have come out with other groups around the world. And I think it's really important. This recent paper with Dr. Conti, he was part of the global guidelines for Wi-Fi. They did a really nice paper showing that PAT was very helpful if we inserted that into the ischemia ring for Wi-Fi. It better staged the patient. So I think the ultimate goal is to get PAT a part of the global guidelines. And there's global adoption. Right now, I currently teach on Zoom. These are all the locations that I'm teaching for future research. So I think the future is really bright for this technique and actually very exciting because it really can help us in the care of our complex patients. Pedal duplex is not just about perfusion and PAT. It's actually about looking into the vessels. We can see calcium burden. We can understand the anatomy. There's so much variation, I think, on the top of the foot, just like the hands-on scanning yesterday. So when we can look at perfusion and anatomy and calcium burden, it really gives us a lot of information. And you can see here, ultrasound is pretty good, and we're looking at 1 millimeter vessels. And you can see this patient has a forefoot or a toe amputation that's healed. Post-procedure is now class 1. This is how we're going to follow our patient throughout the course of wound healing by using this metric. And this is on the bottom of the foot. Again, forefoot amputation. This is a beautiful look at the lateral plantar vein, lateral plantar artery. The artery is pretty healthy in blue there. That's retrograde. So we can really get a lot of valuable information out of duplex ultrasound. And then when we put it all together, when we evaluate the patient's foot perfusion, we understand basically the target artery pathway from groin to toe. Dr. Harris or Dr. LeSar can basically look at that case and plan their intervention based on the comprehensive duplex ultrasound. It's a short CTO occlusion. It's homogeneous. I'm saying, they're probably going to go right through. And single vessel runoff via the perineal artery. Maybe we can indirectly just get blood flow to that fourth toe by just opening that SFA. I love it for our podiatric partners because we work a lot with our podiatrists to say, hey, this is a non-healing wound. Can we just do a quick pedal duplex? These are all neuropathic diabetic foot ulcers. There is not an ischemic component to these patients. They just need medical optimization and good podiatric care and probably some endocrine control maybe. Versus this patients, these are ischemic. You put the probe right next to the wound bed and you can bet that these are all class 4. They need to be revascularized. And so when you start at the foot, at the wound bed, and it's abnormal PAT, it's basically going to shift the way you're going to scan your patient. If it's class 1, I can probably do a pretty quick duplex ultrasound. But if it's class 3 or class 4, which is predictive of not healing a wound, that's not enough blood flow, I am certainly going to map for open endo or deep venous arterialization. So it's going to change my mindset of how I'm going to scan this patient. I want to quickly talk about heel wounds because we have needed a way to evaluate heel wounds. Ultrasound is really nice. You can see this patient has a heel wound here. This was class 4 pre-procedure. Post-procedure, it's class 1, and the patient went on to heal. So we can look at the medial and lateral calcaneal branches to the heel wound, and we can see it with imaging quite well. So again, all you need to do is place the probe proximal to the wound bed, regardless of where it is, and understand what the PAT is to understand the perfusion. Here's another example of a patient with a medial heel wound. This is getting on the medial calcaneal branch. Post-intervention, he went to class 1 and healed very nicely. So let's start with a quick case. This is an 82-year-old male. He's got multiple comorbidities, diabetic, smoking history. He has been seen by vascular surgery many times, as you can see, with multiple interventions. And he was sent to us in Portland to say, this is a no-option patient. What are we going to do with this patient? So you can see he's had multiple failed bypass. He's got significant toe wounds on the first and second digit, and he has class 4 PAT. I'm going to map. Look at the anterior tibial artery is 1.2. We could get some retrograde access, but we still have a lot to go through that's occluded. And I think what highlights about this case to me is thinking outside the box. This guy is looking at an above-the-knee amputation. And the profunda, as we know, is the lifeline of the lower leg. And you can see the pop is open with single vessel runoff via the perineal artery with open communicating arteries. But the target artery pathway to those toes is through the posterior circulation. So I think the profunda is significant here. It's 320. So Dr. Constantino and I decided, let's just do radial access and see what that looks like on table. So it doesn't look that tight with this projection. You can see the hood of the failed bypass grafts. She ballooned the profunda. And post-balloon, it still doesn't look that significant. Yeah, we could do different projections, but here's what's exciting, is on-table ultrasound, pre-balloon angioplasty of the profunda is 320. Post-balloon angioplasty, we see it decrease on the table to 129. It's pretty good. But what's more impressive is that the PAT at the wound beds is class 4. On the table, post-ballooning of that profunda is class 1. Yeah, the velocity is a little bit low, but this is this guy's, I think, only shot. And he did really well. Yeah, the wound took a little while to heal. He had good wound care. And 1 year later, he is completely in remission. His PAT remains class 1. And so this is a good case to highlight thinking outside the box and using tools that may help us care for our patients. Here's a second case. This is a favorite story of mine. This is a podiatrist who was familiar with my work in PAT, and he called me and he said, I'm in big trouble. I've got multiple wounds, and I was seen at an outside institution, and they told me I need a below-the-knee amputation. There is nothing to do. Now, he is a non-smoker. He's been a diabetic since he was 5. His A1C is 8, and you can see here he's got a small wound on his first toe, a wound on his lateral foot, and a significant heel wound. I'm worried about the heel wound because we know those can be quite challenging. So when we look at this full mapping, he has all infrageniculate disease, and he's got a high calcium burden. You can see by this 2-view x-ray that he has those railroad tracks of calcium. Yes, I've mapped the GSV, but I don't think he's a good bypass candidate. In my mind, this is an endovascular, and I really mapped him for DVA, deep venous arterialization, where we connect the artery to the vein. So at this first duplex, the surgeon has the choice to do endo or straightforward revascularization or DVA. So she elected to do just straightforward revascularization. We did antegrade access. The SFA pop is pretty clean, as we would expect by the duplex ultrasound. And now we're going to quickly cross the anterior tibial artery. This is a short 3-centimeter CTO. She was able to cross easily, do planar balloon angioplasty, and here's the foot shot. And yes, we do get an AP view, but still angiographic image here is still subjective. And so we're going to use PAT on the table to determine if we've done enough for this first toe wound. So pre-procedure was class 3 PAT. Post-balloon angioplasty on the table is class 1. And then I'm quickly going to go to this lateral foot wound, and we get the same result, class 3 to class 1. So literally in 20 minutes, we've addressed 2 wound beds very quickly. Now we're going to focus on the perineal artery. So you can see this is an AP view of the wound on the far right. Not a lot of blush there. Now, Dr. Constantino uses a low CC of contrast, so it's not the best angio to protect his kidneys, but she was able to cross the perineal artery, do atherectomy and balloon angioplasty. There was a little bit of vessel recoil that I could see in the blood flow down by the wound bed. She gave some intraarterial nitro, and things calmed down. The result of the perineal was brisk, and it looked really good. And you can see I'm just scanning right by that heel wound, and the PAT is class 1. And even, again, looking at an AP foot shot, it's not that impressive, but the duplex said otherwise. So we follow our patients 1 hour post in the bay, just to make sure there's no vessel recoil and the PAT is still within normal range of class 1, which it is. So everyone's very happy. We follow the patient 1 month post-op. His toe wound is healed, and his lateral foot wound is healing, and you can see that tissue granulation peeking out around the heel wound. At month 2, we now have a healed lateral foot wound, a healed toe wound, and gosh, that heel wound is looking really, really beautiful. And you can see the PAT in the lateral calcaneal branch to that heel wound remains class 1. And at 5 months, he is completely healed. This is a gentleman who was told below the knee amputation, and I think this speaks volumes of how we can think critically and outside the box in these complex patients. So, you know, I talked about his high calcium burden with 2-view x-ray. So when we get an x-ray, Dr. Ferraresi and his group did a great publication looking at big artery disease, or BAD, versus small artery disease, SAD. So small artery disease is below the knee and into the foot. And these patients have a high calcium burden. These patients, I think, may require multiple interventions, and they're challenging. And so there is a working group happening right now. It's a global working group to define no option, because these patients are challenging. So how do we know when to take someone from standard revascularization to this procedure called deep venous arterialization, where that's really known as the no option procedure? So that's certainly work in progress, but these patients are really challenging now when we enter this occlusive disease below the level of the ankle. And I know, Dr. LeSar, you do a lot of pedal work, but they can be very challenging too to keep open or even cross. So I think as vascular technologists, we should recognize the disease pattern of infrapopliteal and inframalleolar and be thinking maybe this might be, in the future, a DVA no-option patients. It's a quick diameter, and look at the pedal venous system, because that's going to be the new conduit. So I think there should be a reflux to just do a quick pedal venous mapping for these patients. So deep venous arterialization, again, is that connection between the artery to the vein, usually from the posterior tibial artery to the posterior tibial vein. We can also do anterior tibial or perineal DVA. And then there's also an open surgical venous arterialization, where we surgically connect the great saphenous vein to the popliteal artery. So this is what the off-the-shelf or LimFlow, that's a commercial system. This is a stented stent graft that goes from the posterior tibial artery across and then down the posterior tibial vein to deliver that oxygenated blood flow around the pedal venous loop system. So this is what it looks like angiographically. And so vascular technologists have to be aware of this new procedure, because we are scanning now the vein that is now arterialized. This is what the hybrid or HISA open arterialization looks like, where we surgically anastomose the great saphenous vein to the P3 segment of the popliteal artery, and we're going to lyse the valves in the great saphenous vein from the medial marginal vein of the foot. So again, when you recognize a disease pattern like this, it is very simple and easy to look at the lateral plantar vein and the posterior tibial veins, because this is going to be the new conduit, because Dr. LeSar is going to put a sheath in that lateral plantar vein to do this procedure. So it's really important that we understand the health and the diameter of the pedal venous system. So after we create a DVA, this is what that's a video. I'm not sure if you can play it. There's it's okay. Well, so we saw, this is the angiogram of the flow going around the pedal venous loop. Maybe we can just go to the next slide, that's okay. And then after the DVA is done, then vascular technologists are going to scan these patients post-op. This is how we're going to follow and track the patency flow volume of the DVA. But far beyond patency and flow volume, this is where it gets really exciting, is now we're looking at new hemodynamic metrics. So why does DVA work? We're now in a venous conduit. Well, I think DVA ignites neovascularity, angiogenesis, and we have this new neovascular bed that then is transformed and developed into the foot. And how do we track that? This is a new test called pedal venous maturation that we will do post-DVA. So when we create a DVA, you can see this is the circuit on the left. That's the initial creation. The lateral plantar vein and the bottom of the foot, there's a space right there called the LeSar's plexus right here. This is the initial creation. 6 weeks later, if we were to do an angiogram again, we're going to see this contrast filling in the LeSar's plexus. That is called angiographic maturation. And there was just a beautiful paper published more recently from the Europeans on this angiographic maturation. The problem is we can't do an angiogram on every single DVA patient throughout the time points of surveillance. So we're going to use ultrasound to determine if there is maturation post-DVA, because we want maturation. We want that oxygenated blood flow to go into the tissue, ultimately to the wound bed to heal the patient. So how we do it is we're going to place the probe in transverse close to the wound bed, and you're going to see this beautiful arterialized pulsatile flow in these serpiginous terminal veins. This is oxygenated blood flow. And then we can measure that by putting our Doppler and measure the venous pedal acceleration time. We do it at the wound bed and at the bottom of the foot. When we see this maturation, this is such a good sign that the patient will probably do very well. The nice thing about this maturation test is we see maturation with the DVA circuit open. And then when it goes down, as they usually do, we still see that same signature of maturation even when the DVA is closed. And so this is really important because I work with Dr. Montero Baker in Houston, who does a lot of DVA, and we see this time and time again. Our paper is almost over the finish line to talk about pedal venous maturation, but it's a very important test. So this was one of the patients at Hope Vascular and Podiatry in Houston. You can see this patient's got significant tissue loss. She's on dialysis, and she's diabetic, and she has that disease pattern that as soon as I saw that, I am mapping her for a venous arterialization. Now, she has a very small lateral plantar vein. We want it to be greater than 3 millimeters, and he ended up doing a hybrid arterialization of her, which was that connection, surgical connection of the great saphenous vein to the popliteal. So we're going to deliver her oxygenated blood flow down her great saphenous vein, around her foot, and then outflow is usually the posterior tibial veins. Sorry, the slide won't advance. So we did her arterialization, and then they performed a guillotine amputation for infection control, and her arterialization stayed open for about 2 months, but she had reached maturation. And ultimately, I don't know if you can bring that slide back up again, ultimately, her DVA did go down, but she had sustained maturation and went on to complete wound healing with that significant guillotine amputation, and she had a heel wound. So I think that speaks volumes to how we can follow our patients throughout the course of wound healing post venous arterialization. With that, I'll take any questions, or maybe Dr. LeSar, if you want to take over from here. There we go. This is a nice video showing her completely healed. Her DVA is down, and she has complete maturation, and she did very, very well. Okay, thank you so much.
This is why Chill's launched after lunch, to keep you guys excited and awake. And it's a kind of a strange way that we actually met for the first time. I was taking a lecture from her, and she had this mapping of the foot vessels. I said after her lecture, I was like, what was that? She said, I can't tell you. I said, what do you mean you can't tell me? She said, it's my research, and I can't tell you. And so I chased her, and we had lunch together, and then I made her tell me everything about it. And ever since then, my techs have been doing PATs for 7 years, I think, some 20,000 patients, something like that. Anyway, I find it very important in the way we think about things. Jill, you've always been on cutting edge, and congratulations on all your victories. So I'm going to talk about critical limb ischemia, kind of strategies to prevent amputation. This is our center where we came live from. Our mission was victory over amputation. We started this company 10 years ago, yesterday. And so, very, very excited about that. And we've grown to, I think, 130 employees right now, so it's a little hard to maintain and manage all these people. Or they're managing me, I'm not sure which. But, critical limb ischemia, this represents the final stage of PAD progression. We don't have to end this way. What happens in the United States is, looking at the heat map for amputations, it happens in the South. 40% of all amputations are happening in the South. And if we get the patient early and can revascularize early, we've enjoyed about a 95% success rate for our patients in preventing amputation if they can get to us first. But the mindset is important. It's really important to have a vision of how you want to handle patients like this. So when we get hospital consults for amputation, we tell them, no, it's no amputation, it's limb salvage. That's really what we want to do. We want to focus on that. And if you have a Rutherford 4 or 5 or 6 patient, which we've seen and talked about before, and they lose their leg, their survival goes down. You can't walk, you don't live as long as you could otherwise. So it's critically important to have that mindset that you must do everything you can to help them. Now, clinical assessment in CLI. When I was a house officer, a surgical house officer, many years ago, and a patient, your daughter came in, and they had periumbilical pain that moved to the right lower quadrant, and they had a little bit of a fever and a little bit of a white count, I would book them for the operating room. I would not be allowed to get a CAT scan. It's really important to listen to what patients tell you, because we knew that patient, that was a 99% chance that was an appendicitis, and we needed to get that appendix out as soon as possible, not delay, get the appendix out. And so when patients, come to you and you're asking them about their history, it's really important to listen to what they say. And you can be prognostic about that. You can make decisions based off those findings. So this is a cute little patient of mine, and the question is, which foot is ischemic? She came in, she said the right was worse at night, and she has a little bit of rubor, and the left, sudden onset of pain in the good leg. So which one's ischemic? Which one? Well, the right is chronic, and the left is acute. So it's both. And it's important to kind of keep that in mind, that the patients will change and represent over time. And obviously the acute one had to go first. So impulse exam is really important as part of our physical exam. We want to hear what they say, we want to ask the right questions, we want to touch them, we want to find the pulses, and then do the testing that we need to do. When it comes to neuromotor exam, we want to watch the movement. You see the toes are not moving on that left fourth, fifth, sixth toe, or the second, third, fourth, fifth toes. The right is fine, left is not fine. It's important to make them move. When we look at sensation, this is a little sped up, but we're checking to see, is she feeling the same on both sides? And she really is not feeling the same on that left side. That left side has numbness right in that area. So when we apply those things that we do with our patients and talking to them, listening to a patient, when she calls me after I saw her that day and I booked her for the operating room a couple of days, she said that night, the gangrene, the blackness is going into my foot now. I said, go to the ER. I said, we're going to figure this out. And so I showed some of the pictures last night at the conference. But this is a 65-year-old patient with rapid progression of gangrene of the foot, diabetes, hypertension, CAD, Rutherford 6, wet gangrene. And on this angiogram, you can see that the posterior tibial artery is absent. The dorsal pedal artery is absent. There's really no surgical bypass options for this patient. The classic answer would be a below-knee amputation to save her life. She has wet gangrene. She's going to die if we don't do something. But what we decided to do was an alternative for her, try to save her leg. And again, patience will teach you, and she was one of the ones that taught me that we could actually do things like this. So we actually took a micropuncture access into that occluded posterior tibial artery. In the right panel, you'll see the needle into the artery, and I'm advancing the wire very slowly as I rotate it. And as we move that wire along, you'll see at kind of the top of the film there, the railroad tracking of the artery. You can actually see the artery, and it's going right in the middle of that. And so when we pass the little catheter through, we could connect from the top to the bottom and then reconstruct the posterior tibial vessel into the foot. We can go around the loop and reconstruct the circulation on the anterior surface of the foot, dorsal pedal artery. And just as we understand nature and understand how the body works, how the heart works, there's different vessels give different blood flow to different regions. And so if you see the red flower over on the right screen, there's one vessel that's feeding that little red flower up there. And so if you have a wound right there, you have to fix that one vessel or you don't have success. So we call that angiosome. And what we knew for her is that we had to have both anterior and posterior circulation. You had to have circulation from the top, circulation from the bottom. This is the 2-week mark after the removal of the wet gangrene, and then at 6 weeks she had a healed wound. And so it's important to apply how you're hearing from patients, what you're seeing, what you're touching, the testing that you do, making good decisions, listen to what people tell us. So this next patient is a 47-year-old white male, pain and numbness in the toes for 2 months, history of aortic occlusion, and it had an aortobifemoral bypass. Again, he's 47. Significant smoker, 1 to 2 packs a day, palpable femoral pulse, popliteal, PT, and DP pulse. He has a palpable pulses all the way to the ankle, but he has 0 toe pressure. Well, that's a telling sign right there. And what do you see when you look at this? Well, what I see is that the anterior circulation seems to be very sluggish in returning that capillary refill. Posterior circulation seems to be a little bit better. When we did the angiogram from an antegrade SFA approach, what we found was that his lesion was at the distal dorsal pedal artery. So if you felt his pulse above that, he had a pulse. If you checked his ABI, it was 1. It was normal. The toe pressure was off. The lateral plantar artery, where the little yellow lines are, was very poor. And so essentially he had no flow into that part of the foot. And so he had critical obstruction at that level. So what we ended up doing was taking a little device to actually, see if I can make this play. Here it goes. And passing that roto-rooter, I call it, down the artery and getting into that area where the plaque was. We could go in and out in that area and actually remove that plaque. And post-procedure, with a good angioplasty, excellent flow now into the pedal circulation. And he had codominant flow in the foot now. It wasn't abnormal. And post-procedure, in the recovery, he said, hey, my numbness is gone, my pain is gone, I'm cured. And that was prior to PATs. We didn't have PATs to tell me, hey, this is not flowing properly. And so we have to go a little bit by what people tell us and what we physically see. So this 69-year-old white female, she had gangrene of her left second toe. She bought a shoe that was a little bit too tight, had a history of hypertension, dyslipidemia, former smoker, palpable femoral pulse, pop, no tibial pulses. And she has gangrene of the second toe. And I was doing a lot of mapping at that time, trying to figure out, well, how does this perfusion work? And I was chasing that idea of trying to understand that circulation. But she had a fairly normal angiogram here. The popliteal trifurcation looks good. Anteriotibial artery had a critical lesion, and there's different devices we can use to actually fix that. But one thing that I was taught I was a young vascular surgeon in training, was that if you're going to have gangrene, there's always 2 levels involved. it's either the heart's bad and there's a lesion like this, or maybe it's the anterior tibial. We chased that into the foot, and we actually found a dorsal pedal lesion that we treated. And post-procedure, 2 weeks later, I could feel a good pulse. She has desquamation of the skin. That means she's making more skin. Things are healing. So it's important to look at your acceleration times, but it's also important to look at the patient. Look at this too and say, yep, this is evidence. There's evidence that this is working and things are going properly. This emergent case was a 69-year-old diabetic male, Hispanic male with a progressive gangrene to his right foot and toes, diabetes, dyslipidemia, former smoker, palpable femoral pop DP, and non-palpable PT pulse. And it's a disaster. It's pretty much gone. The doctors that referred him said that this was an above knee amputation for him, and we thought maybe we could do something a little different with that. And so working with our podiatrist here, we had a good transmetatarsal amputation, but that gangrene came from somewhere. Okay, so you have to really interrogate the vasculature and make sure that things are proper. This is popliteal artery, SFA and popliteal look good. You have good trifurcation, but you do have an area that's an occluded pedal arch. You do have a lateral plantar area that has a high-grade stenosis, and also within the posterior tibial artery that was treated with simple angioplasty. And so after we did that, we checked the pedal acceleration times, and that was important for us to find, is this going to heal for him? Is this going to be enough for him? And so Jill commented about drawing on her foot. This is a picture of her foot right here that she drew on. Am I wrong? That is it. Okay, I have proof. And she's one of those strange people that can do stuff like that, but also the brilliant mind that figured this out. And we're very thankful for her for doing that. These are her pictures as well, her drawings. I am stealing these and showing them everywhere I can. But these are the sites that we use for, we look for acceleration time. And we're looking at that slope, and there's no blockage here, and you can see that slope is very flattened. The acceleration time is very flattened. There's evidence of obstruction. So post-procedure, triphasic waveforms. He had class 1 perfusion. Post-intervention, his rest pain resolved, and his wound healed at 2 months. And so he came in on a wheelchair, but he is ambulating and pretty much healed from that and avoided that above-knee amputation. We had another patient, 73-year-old white male with rest pain and gangrene of his third toe for about 3 months. He had an acute MI that 3 months before, so nobody really wanted to touch him. I mean, you don't want to operate on somebody that's had an acute MI. They can have another one, and we really want that time frame for the heart to actually heal before we move on to do interventions on these people. And so, but he had a former significant smoker, non-palpable femoral, he had palpable right femoral pulse and popliteal, but non-palpable pedal pulses. And so this is his foot exam, or picture of his foot. And I asked some physicians and podiatrists in that one group I was lecturing with, I said, do we have enough perfusion to heal this wound? And we like to have some multidisciplinary ideas, and when you push on that, you see a pretty good return of blood. I mean, it fills right back in. When you push on the toe itself, right in the base of the toe, hopefully it'll play, there it is. You can see it fills in, a little slow, but it fills in. And from that, 7 of the 7 podiatrists said, yes, we should be good to heal after this. I said, not so fast. They said, let's interrogate this. I got a new way to look at this. And before that, we would have to go by physical exam like this. We'd have to say, triphasic waveforms, it looks to be adequate. Is it adequate? And I said, well, let's apply the concept of PATs. Our non-invasive testing showed an ABI of 1.1. Toe pressure was flat. We looked at the acceleration times, and they were class 4 anteriorly and posteriorly. And maybe I differ a little bit from Jill on how I think about that, but I kind of look at the different regions, and maybe not. Maybe we think similar. But the different regions tells me that maybe that we really don't have enough circulation in that particular arterial bed. So I said, okay, let's take him to surgery and figure this out. Endovascular therapy, the first panel, SFA looks good, POP pretty much is good, TP trunk is okay, everything falls apart after that. It looks like we have a perineal artery that is kind of the dominant vessel left in the foot. Everything else is collateral. And what we ended up doing was reopening that perineal with an orbital atherectomy, and you get the picture on the right of more flow to the perineal, maybe more flow to the collaterals. Is this going to be enough? The patient comes back, his rest pain is resolved, there's improved inflow, his rest pain is better. Does he have enough energy to heal? Does he have enough flow to heal, enough oxygen to heal? So pre-op, he was class 4 anterior, posterior. Post-op, he was class 2 anterior, and definitely an improvement, but still class 4 posterior. And my recommendation at that point was to see if we could do more. A patient worked with the podiatrist, said, no, let's get to surgery, let's get this over with. He lost his third toe, he lost part of his hallux, and they were just non-healing wounds. Edge necrosis, kind of a non-healing, poorly contracting wound. And so, reviewing back his angiograms, is there more that we could do? Is there something possibly more we could do? And he did have a dorsal pedal artery. We did enter that where that little arrow is, went retrograde with a wire and reconnected into the popliteal. So now we have 2 vessels, and we have 1 vessel that's actually feeding into the forefoot. And so his post-procedure PATs, although not 1, and I didn't think I'd ever get that with him, but he was a class 2 and then class 3. So we did have improvement on both sides, and we started to see the wound starting to heal, some of the contracting wound, which is what I'd expect, desquamation of the skin. These are all the really signs that you want to see of a wound that's actually, of a foot that's actually getting enough circulation to heal. So PATs can be helpful in that way of telling us, did we do enough? Is it adequate? Can we predict what this is going to happen to this patient? And in my experience, over 7 years of doing this, this method is predictable. I can pretty much say that yes, unless there's infection going on, that this wound should have enough circulation to heal, or this wound is not going to heal based off of these findings. And then what do we do about it at that point? So this is a gentleman that was an 81-year-old diabetic with progressive gangrene to the left great toe, had diabetes, dyslipidemia, former smoker, palpable femoral pulse, pop pulse, non-palpable pedal pulses. And in the first picture, he showed up to the ER with a blister over the end of his toe. Within 24 hours, the whole area turned gangrene, and our ABIs were 0.64. That doesn't seem appropriate. That seems wrong. Our digital pressure was 25, maybe more appropriate. And then our pedal acceleration times were class 3, both anterior, posterior, signs that there's just not enough circulation. So we took him to angiogram. He had 3-vessel occlusion. The perineal was the dominant dominant vessel in the foot. And then right at its at the ankle level, where the perineal artery will collateralize to the anterior circulation and posterior circulation, there was near occlusion. So he just was ischemic, really, from ankle down. We used orbital atherectomy to open this, and his dominant flow is really through a posterior communicating artery into that lateral and medial plantar, and kind of a strange little pattern of arterial anatomy in this particular patient. Now, what we found is post-op 1 week, we start to see that the great toe at the top picture, you're starting to see granulation tissue coming in, you're starting to see some of the slough happening. This is a healing wound. Anteriorly, however, there's a line of demarcation, there's a line that is between alive and what is dead, and there's a tendon exposed. So this is not going to be salvageable. You can't leave that like this. But importantly, his pedal acceleration time was back to class 1. And so that's when I referred to podiatry for his toe amputation. So for 3 months later, he came back to see us. His pedal acceleration time was back to normal. You can see his second toe was very red and inflamed. It's because he slammed his toe on a sliding door before he came to see us. And I said, don't worry, it's going to heal. Your PATs are 1. You're going to be fine. Just don't do that again. So he did very well with that, and it's a way to predict when to operate, when to fix, and it takes some of the guesswork out of in my colleagues of when to do what operation next. We really don't want to work on individual islands. We really want to surround CLI together. We use the best of each of our specialties, and that way we get the best for our patients. When we have a community network for CLI, and that's kind of a concept that I wanted to drive, was that if a patient comes in with primary care, or maybe through the endocrinologist or through the emergency medicine room, they need to get them to an interventionalist or a podiatrist that gets how to work towards limb salvage. Amputation is not the goal. And once we have that connection, then we can actually work on saving the limb and then improving survival for that particular patient. All right, I'll end with no more amputation. And we are moving along really well. So this might be a good time to take any questions for Jill or myself. Any questions? Are you back asleep now? Did I put you back to sleep after Jill's wonderful talk? I hope not. Oh. Okay, my fun fact. All right, I have 2 boys. They're now grown up and moved out. Before they moved out, I decided that I needed to do something with them that was memorable. And so we watched this show called Forged in Fire, and I said, guys, we could do that. And so I have a forge in my garage that I turn on occasionally, trying to burn my wife's house down every now and then. I have not been successful at that yet, but we do metalworking and have fun with dangerous hot metal and hammers and all kinds of crazy things. So, but that's what I do in my spare time. Fun fact. Oh yeah, come back up here.
I have a great fun fact. I referred a patient to you in Uber 2 days ago. So I got an Uber. Of course, he says, what do you do? Well, I do ultrasound. I look at blood flow in the foot. He's like, oh, yeah, my blood sugar is really high. What is it? It's 12. Oh, do you smoke? Oh, smoke for 25 years. Do you have diabetes? Obviously, yes, because his A1C is out of control. Do you have a wound on your foot? Yeah, I do. I was like, you need to go see Dr. LeSar. So I handed over the contact information, and I'll save another limb.
Thank you.